Everyone to this week's edition of It's Worth a Shot, hosted by Mountain Pacific Quality Health. We'll give everyone just a few more moments to join us from the waiting room and we'll get started. All right, welcome everybody. My name is Jessie Kinsey. I'm a registered nurse and account manager with Mountain Pacific Quality Health. Welcome to the 40th edition. It's Worth a Shot. Today is October 19th, 2022. Today we will be discussing some highlights as far as the most frequently cited disease in skilled nursing facilities, as well as discussing a Montana Infection Control Mentorship. We are pleased to have two very special guest speakers from the state of Montana today. And although I know we have some folks from other states, I sure think that you'll be able to pick up some tidbits and information from today's presentation. Next slide, please. A few housekeeping items as usual. Feel free to add any webinar topics or clinician ideas or needs into chat. And same time, same place every Wednesday. And today we do have a polling question. So there's actually two questions for this week. First question, as we look at immunization history, is immunization history requested for patients and residents? And you'll see the selections below. Second question, our facility verifies immunization records for every new admission for every resident. I'll give the folks a few seconds to complete that poll. Participation is always appreciated. Again, this helps gauge and identify needs and align resources. Looks like we still have folks joining from the waiting room too. All right, we'll give it probably another 5 more seconds and we'll close the poll. All right. It looks like majority of folks are requesting that immunization history at admission and sticking by always trying to make sure that's a consistent process. So, all right, thank you guys again for participating in that. As always, special thank you to all our speakers, our attendees, and we appreciate everything that you do, listening in and taking this time to participate. Next slide, please. As we have our snapshot that we have started to include as we've entered flu season, just taking a quick time out to look at the last reporting period for weekly influenza data through October 8th, and we're continuing to see that increase. And I will say that although less individuals tested last week, last reporting period for flu, there was more positive cases within that testing pool. So we'll continue to monitor this trend. It's certainly an upward trend. So a reminder message that if you haven't received your flu shot, now is definitely the time. Next slide, please. And with that, we have our first guest speaker from the state of Montana, Tina Smith. She is a long-term care supervisor within the Office of Inspector General Certification Bureau at with Montana. And she is going to share with us some most frequently cited deficiencies in the long-term care settings. Welcome, Tina.
Ready, thank you. I appreciate that. So I went over all of the information and identified the top 10. And on the next slide, I am happy to say that we are not responsible for the citing of F884, which is the reporting to NHSN for infections and cases. So unfortunately, is what happens is the facilities will report to NHSN, and then CMS actually takes that information. It's an automated system essentially, and they identify those facilities that have not reported, and they automatically cite a deficiency, send it out to the facility. We actually don't even see them, and we don't even know initially that they occur. And that happened 138 times this last year. And every single time that that happens, there is a civil money penalty that goes along with that. And so if you have a deficiency 1 week, they're going to impose a penalty. And if you have it the next week, they're going to impose another penalty because they go for every 7 days. So it really is imperative that facilities get on board with the NHSN reporting. And if you have someone in your facility who's doing the reporting, always make sure you have a backup, because if that person is out of the building, a lot of times is what we're finding is the reporting isn't occurring because that person left and there's nobody set up to do the backup reporting. So it's really essential to do that. So thankfully, we don't do this one, but F884 is our highest cited deficiency for any of the federal regulations. And next slide. All right, next up is F600, abuse and neglect. We have these cited 29 times, and abuse and neglect has been a focus area for a long time, many years actually. And the key areas that we're finding issue is the failure for facilities to actually identify when abuse or neglect is occurring. And that is oftentimes because either the staff don't initially report it, or because they have a scenario that's occurring and they don't understand the concept of what abuse or neglect will be. And so they don't know they're supposed to report it. So that goes back to an educational aspect to where maybe ongoing education or initial education is really important. Also, failing to act on reported abuse and neglect events, where sometimes somebody will report it and then the facility doesn't act on it, or a CNA will report to an LPN or an LPN doesn't act on it, something like that. Failure to ensure they're protecting the residents once they're abused. That is one of the first things that we look at. Just as a hint, one of the first things we look at. So we really want to see what that facility is doing to make sure that that resident who's in that situation is not going to have that harm or potential harm occur anymore in the future. So showing what you do on all of your facility reported events, it's really important to put on what you're doing to protect them. And then failure to educate and provide oversight for staff related to abuse and neglect. This frequently goes to, they'll have an individual that will be a staff member in the facility identified to be involved in an abuse situation, and they'll maybe provide education for that staff member, but then they don't do any future monitoring or oversight. And then unfortunately, sometimes is what happens is abuse and neglect occurs again with that same person. And then we may come into the facility to investigate and find out they didn't have a process in place to monitor that individual or their work activities. So all of those things shown on the slide, they're all very important. And they are key things that all of our surveyors in Montana actually key in onto when they're out investigating a survey. And next slide. Next up, we have F610, abuse neglect investigations, and we had this cited 18 times. So each one of the abuse tags, as you know, addresses a different area. F610 actually encompasses multiple areas. So for this, we have the failure to identify and investigate the reported allegations to where they actually carried through the process to not only find it and investigate it, fully, showing their documentation and the steps they took, but then also making sure they report it with that initial report and then with the 5-day follow-up report. Failing to maintain investigation documentation. That's a big one. Oftentimes, unfortunately, surveyors will go into a facility and request an event and there won't be any documentation. A lot of times the reason for that is because of staff turnover and they don't know what happened to the documentation once that employee turned over. So it's good to have a system in place to where it's a general area where multiple people can access it if needed, specifically like HR and director of nursing and administrator. That way, if someone's gone, somebody else knows where that information is at. It's also good to have QAPI involved to make sure that you really do have that information on hand to show what steps you've taken. Again, failure to provide oversight and monitoring for the staff if they're involved, and failure to utilize or uphold their policies and procedures. So each facility is supposed to have a policy and procedure. And when we go out and we do a recertification survey or even complaint survey, we're required to look at abuse and neglect. So one of those things that we do is we always request that abuse policy, and we look at that to see whether or not you are following that policy specifically. So if you say that you're going to do education twice a year for all of your staff on abuse and neglect, we're going to be looking to see whether or not you're actually doing that. We don't cite specifically on the lack of policies, but we will incorporate that essentially into the deficiency as one of those contributing factors. And then lastly, we have staff failing to report to the administrator or the reporting designee. So sometimes the staff just simply don't know who they're supposed to report to. Frequently, this happens when it's an agency or a contracted staff member. So if you have contracted staff members in your facility, please make sure you have a system in place to where they definitely know who they're supposed to contact, the contact information, where they can obtain that contact information, and make sure that it's really front and center for everybody to access. That way, if there's a problem, you can't come back and say, oh, well, I didn't really know about that, because everybody should know about it.
Called for Dr. Jones for Kent.
What was that? Okay. Can you all hear me now? All righty, next slide. Thank you. Okay. F578 was cited 13 times. This is for advanced directives. When a resident comes into the facility should right away look at what that resident's advanced directives. Do they have any in place? Do they need assistance with them? Are they a full code? Are they a do not resuscitate? You want to make sure that you're following your policies and procedures. If you have a resident that comes in and you identify that that resident is a do not resuscitate and you don't implement that process, that could be considered neglect, or vice versa. You want to make sure that your forms that you're using for advanced directives, make sure that you look at those directions to ensure that they're signed properly, that the proper people have signed them, and make sure they're on the medical record, and make sure that those staff members working on the units know very directly how to obtain and review those documents. A lot of times is what will happen is if we go in to investigate a situation where maybe CPR was not given to a resident when it should have been given, it often falls back to there was issues with the documentation and the staff didn't know where to find it. And so they reverted to the next thing that they knew, which was resuscitate or not resuscitate the resident. It just depends. So really staying on top of your advanced directive should be something that's looked at consistently. Best practice is to look at it at least annually on every significant change assessment, on every quarterly assessment, or if something changes with that resident. Definitely good times to look at it. And next slide. 625 is for bed hold notification. We had cited 12 times. This is usually for not having a bed hold policy and procedure. Many facilities don't have that. A bed hold is not offered on discharge or transfer. A bed hold is not documented or even in the medical record. And the resident or responsible party is not notified or even aware of the bed hold. So making sure you have your policy, your documentation, your forms, and the nurses know how they're supposed to document or who's going to provide that bed hold. Important things. Next slide. 641, accuracy of assessments was cited 13 times. This is for any type of an assessment, essentially. So we're looking at MDS assessments. We're looking at dietary assessments, social worker assessments. It just depends on what the facility is doing at the time. So making sure that those assessments are done timely, that they're done comprehensively, that they're processed in the manner that they should be. And people that are assessing those individuals, making sure that they have the qualifications necessary to actually complete them. Sometimes, not too often, but sometimes we'll have somebody complete an MDS assessment and they don't have the necessary qualifications. So making sure your interdisciplinary team that's involved with those assessments know and they have the skill set necessary. And next slide. 658 is professional standards. We have this cited 20 times. The surveyors look at professional standards if there's a deficiency identified related to a standard essentially not being upheld. They're required to look at the education and training of that staff member and then how they completed the task that was identified as a deficient practice. So normally when this deficiency is being cited, it's because the staff member is failing to uphold current local, state, or national standards. They're failing to have adequate training or oversight, or they're failing to arrange for or provide necessary services. So an example would be you have a registered nurse who has that registered nursing degree, and they have that education and they have the licensure to follow it. And if you have a situation where you have a resident who had a medication that maybe was not given and the physician order was not followed, we would look to see what the process was and where it broke down, and did it have to do with that individual's professional standards? Had they received the proper education? Did they have the tools necessary to do the job? And how did they even know that they were supposed to uphold a specific standard? Next slide. 689, accidents and hazards was cited 30 times. So failure to identify risk factors related to accidents and hazards is one of the main reasons that this is cited. So we really need to look at the residents comprehensively and attempt to actually anticipate what those residents' needs are related to those risk factors. Failing to identify the interventions for prevention of those accidents and hazards also applies, because if you can't identify the risk factors, you really can't implement those interventions for those things. Failing to update the individualized care plan is one of the contributing factors. Failure to implement preventative interventions immediately following or after an accident or hazard. And an example would be you have a resident who falls, and then you have a fall committee that doesn't review for, let's say, 4 or 5 days down the road, and there's no interventions put in place after that first fall. That resident is basically at risk for future falls from the time of that fall until you have that fall meeting. So making sure you have a process in place to implement interventions timely. And then lastly, failure to address resident changes, whether they have a significant change or a minimal change, making sure that you capture that to make sure you are looking at if it's increasing risk factors for that resident related to accidents or hazards. And next slide. 757, psychoactive medications was cited 18 times. And a psychotropic drug is one that affects the brain activity, mental process, behavior, and includes antipsychotics, anti-anxieties, depressants, and hypnotic medications. Typically, this is cited because of failure to identify and use of the medication on or after admission, failure to ensure the medication is not being used as a restraint or it's used appropriately, failure to identify that there's a new order in place, and then making sure that once that order is received and that medication's implemented, that an appropriate care plan is then put in place. And then failure to address the as needed or the PRN use of the psychoactive medications. And then failure to ensure the medication is the least restrictive. Normally, we don't find issues with policies and procedures related to psychoactive medications. So we always would go back to look at your policies and procedures, of course, if we find problems with it. And next slide. And F880 infection control, as everybody knows, is highly cited. We had 38 citations for that. Normally, it has to do with hand washing and sanitizing during care, failure to maintain safety while going from room to room when the nurse is passing medications or the medication aid, failing to properly use protective equipment. Those are the top 3 things right there of why we cite this deficiency. And then we have failing to identify the need of transmission-based precautions and then implement those precautions timely, failing to ensure infection control practices are in place during wound care, and then making sure that your laundry and housekeeping practices are following those necessary things for the disinfection of soiled linens, and then housekeeping services, of course. And next slide. And that is all I have. So those are the top 10 for Montana. And we are fairly consistent in those deficiencies that we cite across the board. We do have some change from year to year, but typically is what we see is that those are the primary ones that we cite, and we may have 1 or 2 change each year, but most of those are usually carried over from year to year quite frequently. So questions we can answer now or later, Jesse. That's however you would like to handle that.
Thank you, Tina. I do
You're
have a
welcome.
question in the chat that I'll let you take a peek at, and then I think we'll go ahead and introduce our next speaker. All right, our next speaker, we have Stephanie from the the Department of Public Health and Human Services with Montana, and she's the Public Health Program Specialist. Today, she'll be discussing the Montana Infection Control Mentorship Program. Welcome, Stephanie.
Great, thanks, Jesse. Hi, everyone. Like Jesse said, I'm a program specialist with the Montana Public Health Institute. And if you want to go to the next slide, I will get going on our Montana Infection Control Mentorship Program. So this program is a partnership between the Department of Public Health and Human Services in Montana, and then also the Public Health Institute and the Montana chapter of the Association for Professionals in Infection Control and Epidemiology. We recognize that there is a need for mentorship and support for new infection control practitioners in Montana. And so really the intent of this program is to match new infection control practitioners with seasoned ICPs so that they can gain some practical knowledge, identify training or educational opportunities, and then build a professional network for other infection control practitioners in the state. Our first cohort began this past September and will run 12 weeks through the end of November. And then we have a second cohort identified and planning to start that this winter. Next slide, please. So our mentorship program materials are based on APIC's roadmap for the novice infection preventionist. And then they also have a competency self-assessment. And so we have our mentees at the beginning of each cohort complete a pre-assessment that consists of filling out the roadmap and then this competency self-assessment, which I'll show on the next slide. And then, like I said, it's a 12-week program. And so that consists of weekly one-on-one meetings between the mentor and mentee. We have monthly cohort calls that feature an educational topic or guest speaker, and then we do mentor-mentee report outs. And then we also provide funding for the groups to do in-person site visits, and so they can go and see other facilities across the state and kind of get a sense of infection control measures that other hospitals are implementing. And then in the spirit, and then we also do sponsorship to the Montana APIC conference, and we'll have a little mentor-mentee gathering so that folks can meet each other in person. And then lastly, in the spirit of continuous quality improvement, we're planning to do an evaluation at the end of this first cohort, just to help us continue to improve the program as we move forward. Next slide. So like I mentioned, our two assessment tools, we use the roadmap for the novice infection preventionist, and then APIC's competency self-assessment. And so really the intention of using these two resources is to help new infection control practitioners prepare or pursue their certification in infection prevention and control if they're interested or don't already have it. And then the nice thing about the roadmap is it outlines those key skills and abilities. And so the new infection control practitioners or the mentees can really hone in on the areas that they want to focus on or build their skills on as they progress in their career. Next slide. And then these are just two screenshots of the materials that we've created. So on the left there, we have a work plan. And so based on the results of the roadmap, or, as the mentee fills out the roadmap and completes the self-assessment, we have the mentee fill out a work plan with their mentor, just to help kind of identify what their priorities are and guide their weekly meetings. And then we also really try to connect mentees to each other, and then ongoing training opportunities through DPHHS. I know they do a lot of like infection prevention office hours and weekly webinars. So trying to get folks exposed to those training opportunities too. And then the screenshot on the right, this is the mentor toolkit that we share just with the mentors to help just kind of outline the roles and responsibilities, key dates, and how the Public Health Institute will provide communication and support throughout the duration of the 12 weeks. Next slide. And then I just wanted to share, this was our recruitment flyer that we used for this past fall. And so really, the benefits of this program, it's an opportunity to build leadership skills. And then we've already heard from both our mentors and mentees that, they've really benefited from that mutual learning experience. And I think we're already starting to see folks building a professional network. And then, like I said, the sponsorship to the APIC conference, the Montana APIC conference, and the in-person site visits are a nice benefit as well. Next slide. And then here's our map. So this is our fall cohort. We have 3 mentors and 5 mentees spread out all over the state of Montana, which is exciting that we have kind of a good distribution across the state. And then, like I mentioned, we have a cohort plan to start in January, and we already have about 8 or 9 mentees interested. And we're hoping that we can get some of our current mentees to apply as mentors for the next cohort. Next slide. And then these are just some resources. I'm not sure if the slides are shared out afterwards, but I just wanted to share the links to those different APIC resources. So the novice roadmap for the infection preventionist, their competency model and self-assessment tool, and then the Department of Public Health and Human Services HAI program, and then the Institute website as well.
Thank you, Stephanie. And these slides will go out next week with the reminder for next week's presentation. So, and there'll be a recording posted on our website. And I know we did have a couple questions in the chat box.
Perfect. Yeah, Jesse, do you want me to take Dana's question? Yeah, it looks like there's a couple questions about the mentorship program. So yes, as of right now, it is just for Montana. But if there's other folks that are interested in setting up a similar program in their state, I'd be happy to chat with those folks, and we can share our resources. And if someone else wants to set up something for a different state, then we're happy to share what we can.
Oh, that'd be great. Would you mind dropping your email in the chat box and people can snag it?
Yeah, sure thing.
Thanks, Stephanie.
Yeah.
And then
Jesse,
Tina.
there was another question for Tina. It came in a little bit earlier. It looks like it says in the absence of in the abuse/neglect investigation is unsubstantiated, then should we proceed to provide oversight and monitoring of the staff that is involved?
You want to in some capacity. So it just depends probably on the situation, but if you have something come up down 3 months down the road or 4 months down the road, are you going to be able to know or remember how many people or who specifically was involved? So as an example, I used to keep a tracking sheet that would have the resident and the staff and the date and a couple words on the event. And I could just use that tracking sheet and say, okay, wait a minute, I had this staff member involved in 3 different events in the last 6 months. What's going on here? So you want to in some way have something to at least take a look, just to see if you have any trends that are occurring. And then the next question that we have was for the N95s and the fit testing. Currently, we are not looking at the fit testing specifically. That's not something that CMS has asked us to go out and actually do. In all of our information that we have, it really uses the wording of making sure that staff are wearing well-fitted masks. And so we're leaving that up to the facility policies and procedures and how they're going to handle that fit testing specifically. And then as far as PPE use and additional precautions, the surveyors are looking at that, and they look at your policies and procedures, and whatever you say is going to happen for those staff that are not vaccinated, we are going to look at procedures above and beyond that. And in the CMS information, it actually shows in the wording what additional PPE will be used, and it's plural, it's not singular. And so we are looking for more than just one thing that you're going to do. Typically is what you see is they may have a staff typically use like a well-fitting mask, and an additional precaution might be that they have to use an N95 all the time, or they have to social distance in specific areas of the facility, or they're removed from direct resident care. So really it just depends on your policy. And all of the surveyors are still looking at the different things that they're doing for the unvaccinated staff. So definitely each survey, when something comes up, they're looking at that.
We did have one more there's a couple more questions for Tina, and maybe what we'll do is we can take those offline and answer them and reply back to the group with next week's Q&A opportunity in the beginning of our presentation. And there's one more question too for Stephanie. The question was, can a non-licensed person do the APIC program?
Yeah, thanks, Jesse. I was just typing a response to Lynn. And Lynn, feel free to get in touch with me directly if you want to chat more. But I think that I just, if I'm understanding correctly, I think we could accommodate a non-licensed person. Do you mean like a non-RN? I think currently all of our mentees do have some sort of credentialing, but I don't see why we couldn't accommodate someone that isn't licensed. Yeah.
Great question, Lynn. Okay. Well, our time has come to an end. Holly and April, I see your questions. We will get them answered. So stay tuned. We'll follow up with you guys. Thank you very much to our guest speakers today, both Tina and Stephanie. We appreciate you, and maybe we'll talk you into joining us again. Thank you, everyone. This concludes this week's edition. Take care.
Thank you.